that there have been shifts the way we think about psychiatric disorders and the way we approach about helping the individual suffering from psychiatric disorders. The psychiatry in pre-modern era, before any effective models of treatment were available, is largely linked with the asylum-based care. Then this moved to different stages, the way psychiatric disorders have been conceptualized and the treatment modalities have evolved. So the bird's eye view of major conceptual shift in psychiatry can be summarized as that moving from asylum to analysis, psychoanalysis, to understanding about molecules. Then the newer neuromodulation based strategies think of psychiatric disorder more in terms of circuits, that modulating circuits and manipulating neuronal excitability in certain specific kind of circuits result into the desired clinical responses. So this is what a basic of conceptual shift in psychiatry. So in pre-modern era, the most important basic shift was from punishment to humane care. That before 18th century, the most important psychiatric treatments that were available were dependent upon closing up the patient and separating them from society and keeping them in asylum for the safety of the person as well as more importantly for the safety of society. However, with the further evolution of understanding of psychiatric disorders, there have been shift from punishment to human care, and we know that the names of Philip Piniel and William Tuke, who introduced moral treatment in psychiatric disorders. So rather than based only on punishment model or separating or secluding them or restraining the individuals, the emphasis was shifted to compassion, structured routine in asylum life, and environmental healing. So making them becoming closer to nature and setting their biorhythm in more proper ways so that this environmental influence can help in healing process. And the key insights from this era can be that the mental illnesses begin to be seen as condition requiring care, not just confinement. And this also reverberate with the similar kind of thinking in different alternative methods of treatment. Like if you read about treatment of psychiatric disorder in Ayurveda, you will find references that in addition to treatment by some herbs, you'll find that the suggested treatment options for dissociation or hysteria are confinement in a room, hanging upside down in a well, and gentle beating. So these are the recommended treatment options in Ayurveda for conditions like dissociative disorders. So I would not say that we can think and ridicule these kind of thinkings in that era, but if we think in terms of that non-availability of any scientific concept for understanding of psychiatric disorders, as well as non-availability of any effective treatment options, led to think that people might be cured in this kind of way and they must be producing some sort of results also. Like in today's also, when I interact with the students, I would say that if you think about the outcome success rate in dissociative disorders, I would say that success rate will not be very different when we treat dissociative disorders by our medical method vis-a-vis the success rate of faith healing. The people who visit temples, who visit Dargah also get cured to a certain extent and they get well to certain time periods. But in scientific concept, we know that there are different kind of conceptual things that are helping them to heal. And those are not the way as a scientist we should promote or understand, but just for conceptual understanding that these are the model where faith-based systems or cultural-based concept do help in management of several psychiatric disorders. which were prevalent to the pre-scientific era also. But after this, there have been developments in modern medicine, and these developments led to development in psychiatry also. And uh, some of the important key figures in psychiatry at that moment, which is it okay? No, it's okay. So the important concepts that started influencing the psychiatry is that the theories developed by Emil Kraepelin, who observed the course of people suffering from severe mental disorder and tried to classify that the severe mental disorders can be divided into dementia precox versus manic depressive illness. This led to understanding that the psychiatric disorders can be observed in a systemic way, and there is a separation in different kind of psychiatric disorders that can be classified. And this classification was primarily based on the phenomenology as well as long-term course and outcome of those patients. So this led a major shift in the way we understand psychiatric disorders. In the same way, around the same times, you can say that separated by a few decades, Sigmund Freud was developing his theories of psychodynamic or psychoanalysis. The work started in Europe, and the world wars interrupted his scientific trajectory of life, and he moved to USA, where the psychodynamic model became one of the most prominent model the way psychiatric disorders were understood at that time. The Freud was influential not only in the scientific circuits of modern medicine and psychiatry, but he also influenced the way people started understanding the human psyche and the way the interplay of internal psychological factors of humanity. And it also significantly influenced literature, art, and other kind of medium the way human psychology is understood at that time. And a sort of dual track evolution, we can say that began that in one way, some understanding and thinking related to biological psychiatry was being developed on the models that were initiated by Kraepelin, where systemic observation and careful evaluation of the patient was going on based on, and other was the hypothesis based model that were developed by Freud. I would encourage the young students to read a book by Jeffrey Lieberman. The name is Shrink. It is a small handbook of 200, 300 pages, but it is a very interesting history of psychiatry in these eras. And it shows that how the power structure in USA changed when the psychodynamic model came at the forefront, and some of the most important influential people who were deciding about the way psychiatric research and institutional models would move were dominated by psychodynamic model. So although psychodynamic model helped psychiatry in consolidating position as a modern medical branch, but it also, as per Jeffrey Lieberman, tried to suppress the biological model. As the most important people become psychodynamic people, so they suppressed all the alternative ways and research and biological models, at least for a few decades. But the development in psychiatry continued, and you all know that at the same time, some of the, at least at that, from that point of view, breakthrough treatments. Now we can criticize that these were very improper and poorly scientific understood concepts, but insulin coma therapy, when it was introduced, was considered a breakthrough treatment. And so is lobotomy. It can be, as per the current standard, can be the most cruel and most kind of punishing treatment for any patient. But when the lobotomy was discovered, it was hailed as one of the most important scientific revolution, and Moniz has been given Nobel Prize for his discovery. He was a neurosurgeon. Uh, uh, Electroconvulsive gamma therapy came around earlier 1938 something, that the different kind of models for influencing the brain and causing seizures were being produced. So the camphor therapy, where camphor was helped to bring about the seizures, and some beneficial effects were noticed. In the same way, Serenity and Binney has discovered that if we give regulated and controlled electric current through the brain, it might bring certain changes and it help in resolving some of the psychiatric signs and symptoms. And now we know that after discovery of this model, ECT has gone through several modifications, upgradations, uh, understanding of scientific basis, as well as protocol changes. And till now, ECT remains one of the most effective treatment for several clinical conditions, most notably for severe depression, catatonia, and where patient is not cooperative or not accepting food, and uh, severely suicidal kind of situations. The conceptual leap here in this era was that psychiatric disorders could be directly modulated by brain physiology. So this was a key understanding that if you do something with brain physiology, and there was a production of general seizures, it led to improvement in several kind of psychiatric signs and symptoms. Although the biological basis for this were discovered later, and we'll see that these biological understanding were utilized for development in psychiatry and several other domains also. After when these developments were being taken place, there were developments in other influential domains of psychiatry, which now we understand are one of the most basic key for our management of psychiatric disorders, that is psychopharmacology. The first molecules that were discovered in psychiatry were chlorpromazine, imipramine, and lithium, and we now know that these were the basic of the psychopharmacology in medications till date. Chlorpromazine was discovered by Jean Delay, the gentleman shown in the picture here. These molecules were discovered surreptitiously. These were not identified as molecules for psychiatric disorders. These were molecules that were identified for some other clinical conditions. And by chance, it was noticed that these molecules can help in improvement of psychiatric signs and symptoms also. So this led to refinements of its doses, the way it might function, the way it might help in people with psychiatric disorders. And psychopharmacology became the greatest enabler of modern psychiatry. And we can definitely understand that it is only the way the growth of psychopharmacology that helped in consolidating position of psychiatry as a useful and scientific branch of modern medicine. So the key shift that led to understanding of search for psychopharmacology was that mental illnesses are also caused by neurochemical imbalances. And it also led to theories of monoamine hypothesis for depressive disorders, dopamine hypothesis for psychotic disorders. And this was not only discovery of an effective treatment modality for psychiatry, it also led to change in the way we hypothesize and understand psychiatric disorders, and the neurochemical basis for psychiatric disorders were researched extensively, and now we know that great progress has been made on that front. Subsequently, in psychiatry, psychiatry was also benefited by developments in physics, developments in the modalities, which led to understanding of several other body organs, including the brain organs, and the strategies of neuroimaging like functional MRI, PET scanning, growth and developments in genetics, and as well as understanding of neuroplasticity. These things led to the change of understanding that the symptoms of psychiatric disorders, they are influenced by neurochemical basis. There are influences by the brain, that they have a basis on neuro anatomical basis of the brain. But when we think about the functions of human psychology or human thing, they are not only localized area of brain that are responsible for production of physiology as well as pathology. There are circuits which help in doing the normal human physiological and psychological processes, as well as they uh, impact the way symptoms are produced and the way the symptoms can be helped in the patient who are affected by psychiatric disorders. So these advances in neurosciences led to the conceptual transformation of that psychiatric disorders can also be dysfunction of brain circuits. In addition to the chemicals, not only limited by specific brain areas in certain cases, there are brain circuits that influence the psychiatric disorders, and this understanding also led to better conceptualization, the way we understand current neuromodulation strategies. And then the discovery of neuromodulation strategies happened, and we are standing here today. That we know that strategies like repetitive transcranial magnetic stimulation, transcranial direct current stimulation, and deep brain stimulation, these technologies not only helped us to modulate brain areas in a more precise and specific ways to treat the specific targeted symptom in uh, the patient who are suffering from those disorders, but they also led to understanding that there can be precision brain modulation in comparison to ECT. That was a general strategy to produce a generalized seizure. There was no precision in that kind of treatment. You cannot modulate that which kind of circuit you want to stimulate and which kind of neuronal system excitability you want to modulate. But these newer modalities of treatment led to this change, that there are certain precision the way you want to influence the brain. So from global seizure reset to targeted circuit modulation, this is what neuromodulation is all about. Now we understand that ECT produces a widespread neurotransmitter surge, that changes in neurotransmitters level, like changes in monoamine, GABA, and glutamate. It also leads to changes in neuroendocrine system, as well as influence neuroplasticity through BDNF and other pathways. And it leads to network effect, that is global synchronization and reset of dysfunctional brain network, as well as normalization of default mode network, hyperconnectivity, changes in hippocampal volume and in connectivity. So these are the prominent strategies and prominent models through which ECT is said to work. The newer neuromodulation system like RTMS causes focal electromagnetic induction, tDCS causes sub-threshold modulation of cortical excitability. So instead of global reset, these strategies are able to help in region-specific modulation of dysfunctional circuits, like in depression, modulation of left dorsolateral prefrontal cortex. So the scientific leap that has happened in this era is that we move from whole organ level, that is brain level intervention, to circuit level intervention, specific and precise way. And also from irreversible lesion lobotomy to reversible targeted stimulation and suppression, tDCS and RTMS, they causes that circuit modulation work. Like in deep brain stimulation, there is possibility that it can be used for certain refractory conditions in a useful manner. And these breakthroughs revive interest in brain stimulation after pharmacology's limit. What about this limit that as we started understanding the brain in better way, at every story which I narrated in my presentation led to understanding of the brain and its system in relatively better way. But it also allowed us to see that what are the limits of this kind of neurointervention. So from asylum-based care to the precision psychiatry, which we are practicing both in terms of psychopharmacology and neuromodulation right now, we understand that a new layer of understanding was added, as well as a new level of limit was set to our understanding. So this is what current neuroscience is all about. tDCS, I hope that next presenter will give a very detailed understanding about this thing, but just briefly, it modulate long-term potentiation as well as depression-like mechanism, work like NMDA receptor modulation, membrane polarization shift, and the key advantages are that these are plasticity can be paired with cognitive and behavioral tasks, so it can be a state-dependent neuromodulation also. It can combine with cognitive remediation, and as well as there are things that it might influence the psychotherapy based interventions in psychiatry. So this is my last slide now. As we become excited with every new treatment strategy and avenue available in psychiatry, so there are a lot of hypes and a lot of over exaggerated expectations from treatment modalities also. tDCS stands at a position where this modality of treatment do have some clinically useful indications in psychiatric disorder. But this is not a treatment strategy which can be helpful for a large variety of clinical patients in all kind of symptoms. This strategy is the evidence base and effect size for most of the studies are reported in the range of small to moderate effect size. So these are not very high effect size data. This is what we need to understand. And also when we are claiming that this treatment strategy is very useful, it can be utilized and used in home-based care, domiciliary care. It can be utilized in variety of setting. It is very cheap and effective treatment. So there are potential that this strategy can also be misused. And we are already reading about that the people are using tDCS before exams for boosting their brain power, their attention and concentration. People are using tDCS for their interviews before their IS examinations. So I hope that as a scientist, this is also our duty that we need to sensitize the people that this is a treatment strategy, and the treatment strategy should only be delivered with the due clinical diligence in supervision of a person who is expert in the discipline, and it should not be misused, and the right kind of information should be disseminated to the public also. Thank you very much for your patient hearing. Thank you.
Thank you, sir, for such a nice and illustrative presentation. If the audience has any queries related to the topics, feel free to ask the questions to us, sir. Also, the online audience can ask questions from sir.
Audience can write the question in chat box if you wish. So I hope there are no questions.
गुड मॉर्निंग सर। सर टीडीसीएस सीजर की थ्रेशोल्ड के लिए भी कुछ उसमें रहेगा। अगर क्रोनिक सीजर पेशेंट हो गए और जो बहुत सारी एंटी एपिलेप्टिक पे चल रहे होंगे तो सर उसमें हेल्पफुल रहेगा क्या?
जी, I hope that the questions will be answered in the next presentation. The TDCS is being used as one of the treatment modality for refractory seizures. So it do modulate the neural excitability in the way which we can utilize in a clinical practice. So the next presentation will answer this question in detail.
That's also working on certain symptoms. Like these neuromodulation, we are also working on certain symptoms. How is that two are different?
Uh, Sir, first, that I would say that this is going to be a very speculative answer. There is no clear-cut response to this question in the way I understand as of now. But the psychopharmacology intervenes the brain in the way the chemical systems are working. And the neuromodulations do influence the brain biochemistry through neuronal plasticity, synaptic level alteration, and neuronal excitability in those pathways. So, in the way we are observing clinically, both these systems can be utilized in a synergistic way for utility of our patients. Ultimately, many molecules and the neuromodulation strategies bring about the similar kind of changes in a specific way, like we commonly do in our clinical practice, that we combined molecules with some different neurotransmitter level, and we often see that in some of the patients we are able to get results which are clinically useful. So I hope that we utilize these treatment modalities which work through different ways of action, and we get some synergistic effect. That is what my best understanding is. If anybody would like to add. Yes.
When we use pharmacotherapy, once it reaches the circulation, the whole brain and all the organs, they are getting the molecule through the circulation. So it is a more of a centralized effect. But when we use neuromodulation, it's more precise. Suppose we know, for example, when we use antipsychotic dopamine blockers that blocks the mesolimbic circuit, mesocortical circuit, inframedullary thalamic circuits, the microstriatal circuits, all those circuits which are regulated by dopamine, they are blocked. But when we are using neuromodulation, it's more of a targeted, not all the circuits. Out of these 5 circuits, we are interested about just one circuit which is responsible for a particular group of manifestations. We can do the more precise information with this without affecting the other relevant circuits. So this gives a additional advantage to neuromodulation over pharmacotherapy and even electroconvulsive therapy. Electroconvulsive therapy causes lot of changes in the brain which are diffuse, not focal. But electroconvulsive therapy, the similar kind of effect that we can get with TMS and tDCS, which gives a focal neuromodulation without affecting the other brain areas. What Sujit had said, I want to comment in relation to epilepsies. Like we know the mechanism of epilepsy is between the imbalance of the inhibitory and excitatory activities, interplay of the circuits, whatever going on. So, with the drugs, we try to inhibit excitatory activities, not potentiate
inhibitory neurotransmission so that seizure threshold is increased and seizures are under control. But say if a circuit will have number of synapses, neurotransmitters, molecules working at different level, and circuit can be excitatory, inhibitory, and if we are able to locate an excitatory circuit which is responsible in a very localized area for the causes of seizure, we can target and we can actually target the circuit and we can control seizures by this way by neuromodulation. So as he said, it is more specific, more precise kind of therapy, but the problem is in identifying that group that's
Hello, sir. I'm Dr. Adarsh, associate professor in psychiatry. Sir, first of all, I would like to thank that you have given a very good presentation on the conceptual progress at neuromodulation. So my question is, in the last part, you said that people are using it for cognitive enhancement before they do all those things. I'm not saying that it should be used like that, but I'm just asking that are there studies of use of tDCS in healthy individuals?
Yes.
Because I think some people say that they improves the working memory and all those memories. So if you see from those aspects, for example, if we sometimes people use some drug like propranolol to overcome the performance anxiety during interview or building science. So how do we see this studies in healthy usual effect of the tDCS in the working body or working memory and use of it in some clinical?
Yes. So thank you for the question. Although I know that some of the answers will be in the next presentation, but I will briefly comment upon what you are trying to touch upon. See, health professional in general and mental health professionals are already blamed about medicalization of human problems in much way. That we already blame that you are keep on lowering the threshold for blood pressure, you are keep on lowering threshold for blood sugar, you are keep on lowering for threshold of several medical and psychiatric disorders to diagnose people who might not be that ill or that might not be in need of medical intervention. So this concept of medicalization of normal human existential experience is one thing which we always think about also as a health professional. We should always think that we should not try to overdo the things. We understand that some anxiety before examinations or before interview or before meeting an individual is not a adverse thing. It is usually productive thing, and lot of creativity, lot of human struggle, and lot of striving for the growth is coming through those kind of human emotions. So if we tend to over medicalize things and we tend to give intervention for all kind of difficult but non-pathological human emotions, there will be a difficult time where we'll be able to draw the lines. So we need to understand that where the need for medical interventions ends, and it is all the time wish for humans that they should not experience any pain or difficulty, and they should get any remedy that can magically treat them from any kind of difficulties or problems which they might be experiencing. So as a health professional, we should think about these boundaries, and we should respect these boundaries, that the interventions must not be used in an indiscriminate manner which led to fall the treatment and which led to degrade the understanding of that treatment for even scientific use. So we must draw that line. And as a health professional, that is our duty to educate the general public, media, and other stockholders in the domain that this is a treatment strategy. It should be used for clinical population in a specific intervention, in specific indication, with a proper supervision of health professional. And this should not be a strategy for home-based self-treatment of, suppose if you try to do this, not more very close to time, if patient will start experiencing anxiety and depression. Instead of going to doctor, they will order a machine of 20,000 from Amazon. They will ask the protocol from ChatGPT. They will see a YouTube video that how to apply the electrode, and they will try to treat their own depression and anxiety sitting in their home. Would you welcome this step? So as a health professional, I would say that this will not be a very welcome change in the way we practice medicine. But medicine practice is a very calibrated science, and that should be done in supervision of experts. So we should not promote the uses which are not very scientific. That is what my take is. Thank you.
Is there any query in the chat box?
So there are some. Okay. Okay.
Sure. So now on, we'll repeat the questions before our